Welcome to the 5-Second Rule Podcast. We are your hosts. I'm Lorenza Howard, and my preferred pronouns are she, her.
And I'm Kelly Holmes, and my preferred pronouns are also she, her.
We have a special episode in store for you today. Today we have Devin Jopp, our CEO here at APIC, who joined APIC as CEO on December 7, 2020. He brings to APIC more than 2 decades of association leadership with a wide array of experience and accomplishments from across the healthcare and nonprofit sectors. Prior to APIC, he served as CEO for the American College Health Association, the principal leadership organization for advancing the health and well-being of the nation's 20 million college students and their campus communities through advocacy, education, and research. Devin received a Bachelor of Arts in Computer Information Systems from the College of Notre Dame of Maryland, a Master of Science in Computer and Information Sciences from Hood College, and a Doctor of Education in Human and Organizational Learning from the George Washington University.
Welcome, Devin. We are so excited to finally have you on the podcast. You know, it's a great experience to have you visit us today. So let's dive right in. Part of the, conversation today is really, Devin, what do you see as the most pressing opportunities and top issues with infection prevention today?
Well, thanks, Kelly and Lorenza. And it's a pleasure to be on the podcast today. I've been here over 5 years, and I think this is the first time I've made it. So the half-decade mark is key. I think, there's so many issues. We're going to have to kind of pack it down. We live in unique and interesting times, as they say. When I joined at APIC in 2020, of course, it was at the height of COVID, right? And I thought, wow, this is the pinnacle of infection prevention control and the challenges. But yet, here we are today in very different times and very different challenges. And I would say at some levels, even more challenging. Let's start first off with kind of what we know, which is, there's a lot happening in the federal government that's having dramatic impact and ripple effect throughout public health, healthcare, and of course, infection prevention and control. We've seen that through dramatic changes of the reduction in the federal workforce. So we have groups like APIC, which really have almost lost most of their funding that we've relied on over the years for advancing research in healthcare-associated infections. We've seen, of course, NIH grants being cut, funding capped, which have certainly impacted academic institutions. We also see, of course, that upcoming there are already approved cuts and planned cuts to Medicaid, which will kick in 2027, which will have significant impact on any hospital that accepts Medicaid, and certainly will force more charity work. And I think all of these create financial pressures on healthcare and vis-a-vis infection prevention and control programs, right? And so where do we make sure we have enough IPs, that our IP programs are fully funded and able to do what they're supposed to do to keep patients safe? On the other hand, too, of course, we see misinformation, right? And I think that has definitely risen to a level not seen before. And I think we all knew and have seen this before, but I think it's become so much more amplified. Particularly vaccines has been on the center plate right now. We've seen, of course, with some of the changes in federal advisory committees around this, where we're putting the anti-vaxxers in some cases in positions that are making policy changes. And you've seen changes recently also with COVID-19 vaccine now requiring, for example, a physician. And I think, really all this leads to, how do we continue to stay on top of these issues at the federal level, but also the state? And I would say that we also are seeing, like we heard recently about Florida, where they actually had they're pulling back on vaccine requirements for school-age children, right? Or we're seeing areas where we're seeing states that are now creating their own guidance in unison with each other or a select set of states. And so this patchwork approach is also another big issue. And I think finally, without being too long-winded on this, is of course HICPAC. And we saw, of course, the disbandment of HICPAC. And that's where we've relied on guidance from the CDC over the years. So I think I end with where I started on this question, Kelly, which is we do live in interesting times. And I think we're trying to navigate all of these buoys in the water at the same time.
Absolutely. And I join you in your sentiments of noting that we are definitely living in unique times. And, earlier this year, the Health and Human Services Secretary announced the dismissal of all members of the Advisory Committee on Immunization Practices, which all members were later replaced. And they recently held their quarterly meeting in September, which resulted in updated recommendations of note to the COVID vaccine and separating. So, for example, the MMR and varicella vaccines. And as you noted, Devin, some states are issuing recommendations separate from the federal government, including my state as an Illinoisan. So I know that APIC partnered with 70 organizations to create a joint letter to the advisory committee. Can you share some insights on this joint letter and further expound on APIC's stance on this matter?
Sure. And I think, Lorenz, we've issued, I think, more statements than I can ever remember at APIC here this year. And I think particularly with vaccines, we obviously have stated concerns around continuing to let science lead. And I think that's been one of the issues in making sure that when we have folks that are on these advisory committees, that they bring the expertise to bear. And I think while we see rollbacks or we hear kind of a lot around personal statements or beliefs around why certain changes need to be made for vaccines, I think the real reality is that we are seeing kind of this challenge to science throughout this and other places in the federal government. So, you brought up this issue of earlier my comments around state-based patchwork of systems, and I think that's really what's going to happen and continue to accelerate. Is in the vacuum where we don't have a strong or trusted federal mechanism for establishing vaccine recommendations, it's going to be up to states ultimately to start setting some of the state policies. What we're hoping is that some of this work that we're doing in partnership with other associations, where we can actually help create that established trusted framework for vaccine recommendations, and that hopefully states will adopt those. That's not ideal in any circumstance. I think, the way we've had it before makes more sense, but it's kind of the world we live in right now. So we continue to kind of challenge the status quo to really make sure that science is leading the way and trying to counter the misinformation narrative that's really been prevalent out there.
Oh, I love that, Devin. And I do agree that APIC has put out so much good information, about that particular topic. And so with those ongoing changes that you mentioned with HHS and CDC, what do you think infection preventionists should know about the evolving public health infrastructure? And then how is APIC engaging with those shifts?
Yeah. I think for IPs, my advice around this is, continue to use trusted sources. And I think always put your eye to the evidence. And I think as IPs, we're trained this way, right? We train around evidence-based practices. And I think, in some cases, we may hear, some of our leadership in CDC coming out with guidance that might not be fully science informed. And I thought I would never say that before, but here I am. And in that case, do your homework, right? Look at what other associations like APIC or SHEA or IDSA are doing in those areas. If it's in vaccines, of course, go look at the requisite organizations that deal with those kinds of vaccine recommendations. So I think, those are the pieces that are really crucial is continue to fact check. I think also, one of the things that we've also seen with the public health infrastructure is some things have stayed the same. And we have seen NHSN continues to be level funded. It continues to exist. And I think we were all very relieved by that. I think, so that's something that's, I think, crucial, as you all know, to the impact to our work as IPs. The other part, too, is I think, we also have seen right now the government shutdown. And I think that is also another complicating factor. The last article I read on this said about 41% of the Department of Health and Human Services will be furloughed or are currently furloughed. And, what does that mean for us? Well, it means that when we reach out to organizations like, trying to get help, reaching out to NHSN help desk perhaps, or trying to reach the FDA on clarity around IFUs that are problematic, we might not get answered. And I think, those, while the NHSN continues to function during the shutdown, some of these areas around what we do and that we rely on are going to be impacted. And I think for IPs, my comment and recommendation is lean on each other. Reach out to your peers, your state chapters, and of course, APIC National to try to get information if you need to get the help and can't get it any other way.
And Devin, going back to your note related to misinformation, as we've noted, it is pervasive at this point in time, and it's definitely pertinent to fact check your sources to ensure that you're providing the appropriate and evidence-based recommendations. So, but with so much information circulating around public health issues today, what would you like to share with our listeners about the role of IPs and how we can help foster trust and clarity in our communities?
Yeah. And, I think as IPs, we have such a privileged space and an opportunity to help be a part of correcting the narrative. And, I will be honest with you, I have family members, right, that buy into some of this misinformation. And, here I am at APIC, right, as the CEO and having to correct this information. And I think this plays out in our families, our communities, of course, in our facilities. I think a couple things, Lorenzo. One of them is, be informed, right? And I think, make sure that or take opportunities to go and make sure that you're looking at the information. And when something comes out, I oftentimes think about recently we heard about Tylenol, right? And whether pregnant women should take Tylenol. Well, if you go dig through some of the evidence, there's a lot of other evidence out there that we have to take a look at. And so where before we might be able to kind of trust something that just came out because it came out of the CDC or federal government, I think we have to question that. The other part of it is, and this is kind of the basics of misinformation, is when we have opportunities to re-observe misinformation, is trying to also gently correct it, right? How do we put the correct information out there? How do we make sure that we actually let them know where we're getting our information from and why the information sources that they might have, where they've got their information might not be the most valid, right? And I think I always remind folks that particularly when you're watching news channels these days, it's more entertainment than news. And you have to sometimes really take that lens and understand that you've got to look at multiple sources in order to really understand where the actual truth is around things.
Absolutely. And that's a whole conversation in and with of itself. Even that during the COVID-19 pandemic, just in us learning and understanding the most effective and strategic approach that we can take to counteract misinformation and share information that effectively, shares accurate and detailed information. I know there have been stakeholders that have convened with presentations on how we can better improve our communication efforts to counteract that as well. And I wanted to pivot related and to discuss leapfrog at the moment. And I'm pretty sure many IPs are definitely following this conversation closely about leapfrog as their organizations adhere to their standards. So I'm curious to know what prompted APIC to formally request that the leapfrog group revise its hand hygiene observation requirements, and how does APIC's evidence-based approach differ from leapfrog's interpretation of the World Health Organization's guidelines?
Yeah, this has been a longstanding issue that we've had some challenges with. And I think, to be clear, Leapfrog really does amazing work in advancing patient safety across hospitals. And I think that accountability that they bring is crucial. And APIC has a very strong alliance with our friends from Leapfrog. However, it doesn't mean that we can't point out sometimes when there's a foul ball, right? And I think this is a foul ball moment. When they set this, from what we can see, when they looked at some of the World Health Organization's guidelines, I think it looks to me like there was some misinterpretation around the time frame that they were looking at for establishing the units and measurements in their standards. And so that kind of 200 units piece wasn't meant to necessarily be a monthly goal, right? It was over a period of time, but it became enshrined into the standard. And now I understand there's been 100 versus 200 and some changes recently, but I think the bigger issue is more better when it comes to hand hygiene, right? And I think, as we started out looking at it, APIC's Research Center started looking across 60 plus hospitals and hundreds of thousands of observations. And we found that really there's no statistically big difference between doing 50 units of hand hygiene and 200. And so that's what led us, Lorenzo, to really going back to them. We went back last year and it hadn't changed. And so we were running up the hill this year. And I'm a little optimistic. I think we've got some opportunities. We've kind of talked through this. One thing I will say that was interesting is if you go read an APIC study, an article that was published by Leapfrog this past year on their standard, and you dig through the data, you'll realize that actually it took them 20 minutes per observation of hand hygiene. If you do the math on that, that's like 60 hours just for doing 2 units of monitoring and hygiene. It's just not pragmatic. And so I'm hopeful that some of the common sense, that the approach that we're bringing in our science behind it will help convince Leapfrog to make a pivot and let us focus on some of the other things that we need to focus on. So, more is not necessarily always better.
Oh, I love that, Devin. Yes. And I think that, presenting the science is always, going to maybe change the recommendations. So there's always new science coming out, with the hand hygiene recommendations. And we've had some great studies out of APIC that have, really bolstered that. So yes, I'm excited to see what the outcome is going to be in that space. But then, slightly pivoting to the APIC is convening their first ever summit for the IFUs and possible strategies to increase standardization. And that's coming up, right, in November. So would you mind sharing with us, what prompted the summit and what outcomes you have hoped that will come from this discussion?
Yeah, thanks, Kelly. I'm really excited about this. And I think, really this comes from our members, our IPs. And I both of you on this call understand better than anybody. IFUs are a real problem in the healthcare system, and they have been for a long time. And I feel like there's been a collective kind of shrug of the shoulders going, well, we can't fix it, or Congress needs to fix it. And that's, yes, but that can't be all of the narrative. And in fact, I don't think it is the complete narrative. So we started digging in saying, well, what does the CMS's COP say about this? And how are they being interpreted by accreditation organizations? And when you look at it, wow, there's a wide variation. Not within the same, even, for example, standards organization. You might have one surveyor that comes in and is very concerned about X, Y, and Z, and another one comes in, it's APC. And then if you go between accredited organizations, it's even more widely different, right? And how can that be when both accredited organizations are, in essence, accrediting against the same CMS COP standards? And so as we drilled into this, and I give the accrediting organizations a lot of credit for this, they all jumped in and raised their hands to come to this summit to discuss this. And I think they all understand the challenge and the problem. Now, we're focused on low and intermediate disinfection. And I just want to clarify that, because I think, when you start getting into the high level components, there's a lot of other factors around this. But what we're trying to get at the baseline is that standards organizations will hopefully agree to a common framework, first off, for IFUs, like risk assessments. How do we do these? When are they properly done? What's the decision ladder around this? And then we can train the surveyors and also the individuals, right, in facilities around the same tool. The second is what I'm hoping that we gather is a set of principles that standards organizations will go back to their standards and really agree to look at. How do we make sure that we can accept a properly done quality risk assessment for low and intermediate disinfection when we're dealing with a problematic IFU? And I think that's crucial. We're not trying to give everybody a pass on IFUs. I think we're specifically dealing with problematic IFUs and also properly defining that. So I'm excited about this, Kelly. I could go on for hours around this. We could do 5 of the podcast, but I won't. So that's kind of what we're doing.
Yes, I love that. I love that, Devin. I so appreciate you taking the stance on this. Like, it is going to serve infection preventionists. So I'm super excited to see the outcome of this.
And I'm pretty sure we speak on behalf of many stakeholders within our profession about our excitement related to this, to, assist in removing the ambiguity related to this, right? We know we want to be adherent. However, how can we remove, as Devin, you noted, those problematic IFUs and ensure that there's continuity? So transitioning into discussions related to global health, I know since I've been in IP, I really loved, I love seeing us grow, not only as APIC, but including CIBIC, our global health efforts, which is absolutely integral as we work towards global health initiatives. We can't just, with worldwide travel, global health is absolutely key in mitigating infection spread. So Can you share with us how APIC is contributing to global health efforts, particularly through its international collaborations, support from global partners, and joint initiatives with organizations?
Yeah, thanks, Lorenza. I've been really excited around this work as well. And as you all know, we're part of the fabric, right? And you pluck a string on the other side of the globe and it can sure impact the U.S. And I think as an organization, APIC, it represents the global community. A couple things, too, I would say. It's first off, regarding WHO and whether or not the U.S. is no longer a member, which is the case, that has not impacted APIC's participation in WHO. We are a member of the global IPC network, which is a WHO-invited network of organizations, and we continue to be very active in that partnership. And so I'm very proud of that work. APIC actually helped develop the first ever global IPC action strategy plan, which was actually launched about a year and a half ago, and was excited around the kind of really being able to drive that forward. And how do we make sure that we are united with colleagues from around the world? The other thing is I'm excited to announce right now, in fact, is that the APIC's mega survey for the first time is being fielded outside of the US. And so our colleagues in the Australian IPC Society actually are using the mega survey. And I'm excited to see what kind of data we get, because this will be the first time we've ever studied IPs in a different country and trying to normalize the data around that. We also did some great work with our Canadian colleagues as well as our Australian colleagues on that. If you saw that ethics framework that we built out, I think that was such a fantastic partnership around how do we deal with the gray zones in our profession when we have to deal with, ethics issues like in COVID certainly showed us a ton of those. And then, of course, we've done some new MOUs with like our colleagues in Japan around kind of some joint education work. And also our colleagues in the Middle East, we actually have some new relationships to try to do APIC training and certification in the Middle East. And so I'm really excited about some of the work like in UAE or Saudi, where, by the way, Saudi would actually pay even for folks to go get their CIC and pay for their exams, prep courses. So more countries, please take note. Let's do that. So those are some of the things that we're doing right now.
Oh, that's so exciting, Devin. That's so exciting. And, just being able to provide those standardized best practices for people around the world and have them be adopted. And I'm so excited to see how APIC is taking, a role in that and, pushing that out and providing that education for people. So in that essence, what APIC initiatives are you most excited about in 2026? So like what's coming up?
Yeah, well, you probably could guess IFUs continue to fill my bucket of excitement.
Bring it. Yes, bring it.
So I think a couple things. In the first quarter of next year, we are going to release our first ever Dirty Dozen IFU list. And this is exciting. This is our opportunity where we're polling our membership to go find out which IFUs are we struggling with and how do we publicly list them. And also reach out to those organizations to help them figure out how they can remediate these IFUs. And so I think if we shine a light on this, that's something that's going to be really exciting and move the field. I might tweak this, by the way. I had just a discussion yesterday. We might also release a squeaky clean IFU list, which will be the best.
Love that.
Right? So we got to, not just the bad, let's pick the good. So that's
so amazing. Yeah. So we're kind of like, addressing, whose IFUs are not meeting expectations and really like how that challenges us as infection preventionists. So I do really appreciate that.
Thanks, Kelly. Yeah, it's exciting. The other part, too, is if you haven't had a chance, of course, our staffing calculator has gotten a ton of traction and use. We're expanding that to actually include epidemiologists into that. So hospital EPIs are going to be added. But the big news around this is we have our ROI calculator that's going to be added. And so our research team is busy feverishly collecting and collating evidence. And we're hoping to roll this out by the end of 2026. That will allow IPs to actually start better justifying their programs and their staffing by tying it to real ROI. So this is one that I think has been a long time coming, and I hope I will excite and support our members.
Absolutely. And that ROI calculator, I anticipate that, definitely. I definitely have utilized or have conducted literature reviews to try to, gauge and garner insights related to the value that we bring to respective organizations. So to have such a tool will be of great benefit. And so I'm pretty sure that myself and Kelly can sit here and talk to you, Devin, and pick your brain for hours upon hours and learn of the exciting efforts that are set before us. But as we bring this conversation to a close, Devin, what parting wisdom or message would you like to impart to those tuning in?
Yeah, I want to encourage all of you out there to know that how important you are and your voice is. And, every IP, while we think sometimes these problems are insurmountable, every IP and that voice that you have and that expertise that you have is crucial. And I think, a lot of times when people do Hill visits, they get nervous. And I say, don't be nervous. You are a 5th degree black belt IP. You are dealing with someone that doesn't even have a white belt in infection prevention control, right? And so I want to encourage all of you, be that voice. And it starts at home, right? It's being that voice against misinformation. It's in your community, right? Reach out to your state legislators, host a visit to your hospital or facility if you can get your leadership to support that. Have them come speak at your chapter. Letting them know the important work that we do, I think will continue to resonate and really move forward, us as the Republic on this issue. And I think, our work is never stopped being important. And I think we just have to continue to remind folks that now more than ever, we have to make sure that's our North Star. And so use your voice, I guess, is my closing recommendation and advice.
I love that, Devin. Thank you so much. I think that is just such a positive note to leave with infection preventionists in today's, kind of mindset with everything that's going on. So you've offered so much wonderful information and, valuable insight in how we can keep moving forward. So thank you.
Thank you, Kelly Lorenzo. Really appreciate it.
Thank you, Devin. It's been a pleasure.
Thanks for listening to APIC's 5-Second Rule Show. We want to hear from you. Visit us at www.5secondruleshow.org. That's with the number 5, where you can contribute to the conversation. Make sure you subscribe and rate us wherever you listen to your podcasts. We're so appreciative of the hard work each of you do every day to make a safer world through infection prevention. Remember, IP stands for Important Person. You are awesome. Stay safe, and we'll see you next time.